Welcome to Acute Conversation, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Ashley.
And I'm Leo. Today we chat with Kathy Lee Bishop, recipient of the Katherine Harris Educator Award. Today we discuss student readiness for the acute care environment, the value of an acute care clinical experience,
and how your acute care skills may come in handy on the tennis court. Let's welcome our guest.
Right. Thank you everyone out there that's listening to the podcast. Today's guest, we have the 2024 Katherine Harris Educator Award, Kathy Lee Bishop. Kathy Lee is hailing from Atlanta, Georgia, from Emory's PT program. Kathy Lee, welcome to the show.
Thank you so much. What an honor to be here with both of you and for all the audience that's listening and hoping to hear something fun.
Now, my first experience with Kathy Lee was working with her for Bridge the Gap. So we had our Bridge the Gap conference in Chicago a couple months ago in May. So this is the first time. It was interesting as on the plane back from CSM, I actually ran into one of your students, Shannon Possard. And what was amazing is she had nothing but great things to say about you and her experience with you working in acute care. And so I think it's befitting that you got the Katherine Harris Educator Award. Could you talk to us a little bit about what does that award represent in terms of being an educator?
Well, for me, it's an absolute honor because I can't tell you how much I have a passion to teach about acute care, and then to be recognized by the Academy, it made me a little teary and, appreciative of all the work I do, but I don't have to have an award for how much passion I give to my students day in and day out and try and get them to switch from sports when they come into DPT to, oh my God, we love acute care. We had no idea. We're so glad you kind of helped guide us that way. So, but yeah, I was very honored by the Academy to receive this award.
Awesome. Can we take it a step back a little bit? How did you first even consider physical therapy as a profession? Can we take it from there?
Well, it's interesting that you say that. So we just passed Father's Day, and my dad was a big influence on me, and I saw how regimented and organized he was, and I thought, well, then I need to go in the military so I can be like him. And my parents sat down and they said, well, how about you go to get your bachelor's of science first, and then if you still want to go in the military, we support you. And so my dad had helped build and design I'm blanking on it, right? The Allied Health Building for the University of Vermont. And so he got me an interview with one of the faculty members there, and her name is Dot Page. And I didn't know anything about physical therapy other than something my mom had been through when she broke her back when I was younger. And I was like, well, okay, how hard will it be to get into physical therapy school? And then I realized it was a challenge, and I was initially waiting listed. And then when I got accepted, it was actually the same day the first grandchild was born into the family. So my getting accepted to college was completely wiped out for that first grandchild. And so I had to do things along the way to make sure that my folks recognized me too. And so I just actually loved PT school, was challenged. And it was so my first experience, we had to do these 1 day a week clinics, and I was going to a cystic fibrosis clinic, and I was like, okay, I'm going to read everything about cystic fibrosis. And I went in like, I'm ready. And I go in, and the young lady's looking at me, and she sees I've got my crisp like polyester coat on, and I'm like all excited with my, my patch that showed physical therapy on my arm. And she's taking a nebulizer, and she's like, oh, I'm so exhausted. And the back of my head goes, oh my God, I was right. She is going to die. And she goes, yeah, I've been skiing all day. And I went, what? And she goes, yeah, I'm exhausted because I've been skiing all day. I'm like, and I literally said the word, but you have cystic fibrosis. And she goes, so that's not who I am. And I went, bad me. And I said, I just had read everything in a textbook, and I thought I knew. But what I didn't take was the human aspect. And so that bit me, and it made me have humble pie. And I just wanted to then learn as much as I could. So sorry, I'm sure that wasn't a question you threw in there, but I was just like, that's really kind of what connected me to my love of heart and lung and acute, and just being humbled by patients every single day, just not thinking about a diagnosis, but thinking about where could this person go? Like, they're not saying, woe is me. They're saying, where can you help me? And I went, that's a challenge. I'll take it on.
Very cool.
And what a cool story too, to like have your patient be the first person to really like hone in on that, right? Like, well, just because I have this disease doesn't necessarily mean I can't do all these things. And you kind of come full circle, like from your patient teaching you that. And now you're teaching like hundreds and hundreds of other people this thing. And in fact, like my first encounter with you was when I first came to Duke and started teaching the cardiopulmonary course. Somebody that used to work with you, a colleague of mine now, was like, you have to meet Kathy Lee Bishop. She's amazing. And I think he connected us. And we actually had a couple of meetings where I like would using you for some advice of like how to start teaching and running simulation labs and things like that. But you're incredible. And I mean, for our listeners who do not know this, she wrote the textbook for acute care. So I'd love to also know kind of like, how did you get into like writing this full-fledged acute care textbook?
Well, I have to do a call out for my colleague, Dan Malone. Yeah, we worked together at the University of Penn in Philly. And we just, it was an incredible experience there where there were so many different ICUs. There were so many different kind of diagnostic categories. If you think now what, we have for a DRP and a DFP for residency, here we were at Penn and we had oncology, we had wound care, we had, GI, GU, we had cardiothoracic, we had all of those there. And I just went to one of the therapists that I worked with, Carrie Kotler. She made a decision to move over to publishing. And she was like, hey, you know how you're always talking about this, this, and this? She goes, what do you think about a book? And I went, well, not alone. I cannot do it alone. So I pulled in all my friends at Penn and we, said, let's just take category by category. And really the book was written out of love for all of us that worked at Penn at that time, because we did have such a great experience. But we had knowledge that there really wasn't a lot of other textbooks out there. One of my former colleagues from Mass General, Jamie Paws, he has an acute care book and it's amazing also. But we wanted to kind of do it with a different slant. And that's kind of what we did. But, you can't read the sarcasm between the line, but working with Dan and all those other folks at Penn, there definitely was, to keep us moving forward, a level of sarcasm to keep us going.
That's great. Now, so you had alluded to this patient of yours, which is first of all, I think that's such a great teaching moment. And the fact that we can hear that you take ownership of that. And that was such a good experience for you to be able to say, you know what, I definitely made a mistake. I misjudged this patient that's still skiing. And then your first exposure to kind of how cardiopulmonary. When was it within your PT program that you started to realize that acute care is where I want to be? Was that during clinicals? Was it during the didactic portion? Was it right after PT school? When did you find your love for acute?
Well, that's a great question. So I was actually on my second long-term up at Central Maine Med in Lewiston, Maine. And I happened to be on the pulmonary ward with all the young people with cystic fibrosis. And they would play tricks on me. And they would do things to try and change their breathing patterns and their breath sounds and pretend they were not the same patient. And this is when there was a ward. And I thought, oh my gosh, if they have this much energy to pick on me, I can learn from them. And then there was this other young fella, oh my gosh, he was about 5 and he had just a horrible, with you name it. And he ended up having a trach and he used a walker. But what they did in the units is they shut the doors a certain way so that he couldn't escape, because they let him, he'd get out of his bed and get with his walker. And you just hear, as the trach was just gooing stuff. And he was it was like, the children taught me so much that, yes, they had pain from surgery. Yes, they had pain because they were in the hospital and missed their friends, but they didn't care. And for the fact that they were still playing tricks on me and had that energy. And, there was this one other young lady that I got off the elevator and she was only 9 months old and she was at the very end of the corridor and her crib faced me. And as soon as I stepped off the elevator, she started crying and crying. And when I got to her crib, her mother goes, oh my God, I said, no, she's got great lungs. This is really good for her. This is exercise. And the mother's looking at me like, who are you? And I was like, I'll take the child crying because I know they're getting gas exchange and they're expanding their chest. And the mother's like, jerk, my daughter, because you're missing the point that she's crying. And I'm going, oh gosh, no, I'm not missing it. This is a wonderful opportunity. Thank you so much. She's like, okay. So again, I thought I was going to do pediatrics. That was, I worked one of my long-term clinicals was at AI DuPont in Delaware, and I just pediatrics. And then it wasn't just pediatrics, it was acute care pediatrics that really just did amazing things for me and taught me so much. And when I went to work at Mass General, they had, you had to do rotations. And so whenever it came to the pediatric rotation, which was the NICU and the PICU and then the regular floor, I would kind of like bow and hope my, manager didn't see me. And at one point she called me and she goes, I've noticed for some reason you're missing this rotation. I'm like, no. Could that possibly? Because I was petrified of the NICU and PICU because I've been with little guys that could, respond back to me, not having so critically ill. And then I just, again, fell in love. It was just a great experience. And, having a child be able to be held by a parent in the NICU, it was just an amazing experience. And it taught me so much. When I happened to be with a young man who had cystic fibrosis when they found the gene. And I still remember that moment when I said, this is amazing. And he goes, well, but not in my lifetime. Like he had the wherewithal of knowing that he had cystic fibrosis, that, he had challenges. It was wonderful for the future individuals with cystic fibrosis. He had the insight. And I thought, think about the humanity that so many of my patients taught me. And he was one of them. I still remember Eddie. He was just not in my lifetime. And I went, but he goes, I don't know how.
Yeah. Yeah, that is a good lesson. And we do get excited about sometimes these like medical innovations, like the new CF drug that came out fairly recently, but people now that are older didn't get the advantage of that. So that's so true. I would love for you to talk to me, Kathy, because in my interactions with you, you're so passionate and I feel like so great at making sure students are ready to enter the acute care environment. But I think there's a lot of people listening maybe that are either educators themselves, maybe students, or maybe clinicians that are going to be receiving these students. So talk to me, how do you ensure students are ready to enter this very complex environment? What do you do and how do you prepare them?
Great question. So, one of the things I'm blessed with here at Emory is we have the School of Medicine has a simulation center. And, I can stand in an auditorium and teach people and show slides and have videos. But for them to actually touch, feel, and hear, it's a wonderful use of simulation. And so I'm able to take the first year students in at least 4 times into our simulation center. And sometimes it's just starting with the basics of this is what a heart and a lung sound is. But they're focusing on the high fidelity mannequin and it's blinking and they're not listening to me at all. And I'm like, okay, let's step. This is a high fidelity mannequin. They've got pulses and they've got a blood pressure and they've got heart sounds, breath sounds, and they can do these things and they'll have neurologic responses. Now let's step back and now let's assess them. Because walking in, even though we all know it as educators, it's a simulated acute care for a student the first time. It's like, because oftentimes coming into PT school, you can do an outpatient, more of an observation, and you don't really have opportunity now since COVID. There's fewer opportunities for our students to really see other aspects of PT that would be whether at a rehab center, subacute, or even a hospital is very limited, which I understand. Protect the patients and really you protect students. But to see a student go really wide eye and you're thinking, this is simulated, right? That there's this glass pane is two-sided and there's someone doing this for the mannequin and they're like, what? And so it's really exciting to then take them to be able to, okay, so now touch them. Let's go ahead and do it together. And just being very calm and really trying to be intentional about making that this is simulation. You've kind of gone into a contract thing that you are appreciating this is what an acute care simulation would be. And you need to treat even the high fidelity mannequin as Mr. or Mrs. Jones. And you need to show them respect. You need to drape them. And so once the students kind of get over that fear, it's a really wonderful experience. And then we kind of scaffold it in that let's have it where you have a couple of more lines and tubes and, identify these are the rhythms and how do you still walk in and make sure you're human to that patient. And that's their room. It's not your room.
Right.
Oftentimes I'm really teaching them about respect
Mm-hmm.
of,
Mm-hmm.
of the person. Like, please don't put your clipboard on their bed. And they're like, well, why? I said, well, would you want someone to come in your bedroom and put something on your bed? Would you? And they're like, no. I'm like, well, so let's do it that way. So trying to use simulation to help the students kind of like appreciate some of those things. And then when they come back from their first clinical, they'll be like, well, but Dr. Bishop, we saw it this way. And I'm like, okay, well, we're trying to teach you to raise the bar in our profession.
Yeah.
How could you change it? And so they're like, I said, you learn so much from your clinical instructors, but how much more do you want to take our profession? Like what else did you learn, or put that information in a box? And each time when you see a new patient, add to the box and then make clinical decisions out of that box, because not everyone's the same. So
That's so interesting. Just thinking about even getting into PT school, the number of students that I have that have never either themselves been in a hospital overnight, right?
Right.
The exposure of being in the hospital.
and who
Yeah.
wants to?
Right, exactly. And just the concept of it, which like these are patients that are here in the hospital, and we're going to work with them, and we're going to try to do as much as we can for them. And a lot of students that get into PT school, they might not even have any concept of what acute care looks like. And so what I want to ask you too now, just based on how simulations is, how have you seen things, the playing field, how has it changed compared to when you were first teaching, now that we've added in more simulation, and just how the profession has changed? How have you seen that PT education change, and has it been making an impact to our students during their clinicals and eventually as professional? Have you seen any change there?
I feel like,
Go ahead.
but before you answer the question, I think you can also tie in like how much more I think complexity has gotten too, right? So I think that's guided some of that change also.
Yep.
I think like we developed our ICU simulation elective back in 2014 was our first cohort.
Wow.
And since then, we've taken those 10 simulated cases and we've layered them, because ECMO wasn't standard of practice then. You know, the LVAD patients, the patients needing the left ventricular assist devices, were a little bit different. And the type of LVADs we had back in 2014 are different than are here. And so even if you develop an elective that's simulation based to prepare students for early mobilization in the ICU, you've got to involve with. We now bring the ECMO team over here. We used to take the students to the ECMO wet lab in the hospital for them to have the training over there. But now we can actually bring their equipment here to our simulation lab with our standardized patients. And we make the students actually when we have the LVAD case, we make the students undo the batteries, redo and change out a power pack, so that they understand that if you're the therapist taking care of the patient, you've got to know the technology to help that patient. And, I think it's really cute. We do kind of like a confidence scale at the beginning of the elective, because they've been on their clinicals. They're all like, oh, I walked a patient on ECMO. And then you do the confidence, and then we give them the first simulated case where we're pushing them, and they kind of like go, oh, maybe there's more I need to learn.
Good. That's a good thing.
Yeah, it's a very good thing. You hope that they identify that this is, for all the technology that just keeps changing, we have to change with it. Like, we have to understand flow and sweep and the different ventilators that have changed. Like, when I first started teaching, we had very limited type of ventilators. And now the ventilators are like Bentleys, they can do this, they can do that and this. And so you can't ask a student, when you're talking about entry level, to know everything, but you can at least have them understand minute ventilation. You can at least have them understand, why is this person's respiratory rate up or their volume down, or why is the pressure off, so that they can do basics when they walk out of a program and graduate, because you just cannot. You cannot teach them everything. Even though I want to, you cannot.
Kathy, I'm curious, with all of your knowledge and experience, this is going to be a pie in the sky question, but I'm like, where do you see acute care headed? Right? You think it's direction of acute care, because I feel like you have a lot of knowledge. You've seen how it's changed over time. You teach it. You're very current and relevant with it. So where do you see it going?
So, I mean, I really so just at the Bridge the Gap conference, they talked about high intensity gait training in the ICU. And I immediately thought back, well, okay, what's the evidence? Are we doing this, and does it matter, and what patient population? And so I really think when you look at acute care, one of the things that Bridge the Gap showed us was evidence, evidence, evidence. And I think if we keep utilizing that, and as technology changes and patients survive things that they wouldn't have survived, we need to keep moving with it. So I would love to say the word evolve. And I hope acute care and therapists that work in acute care never resort to just walking people. That walking with a purpose, if that purpose is gait training, balance training, endurance training, that that patient that first time around the corridor and there's a bell where they're like, oh my gosh, you made it around, and you ring that bell. Okay, so now where do you go? Do you progress them to more high intensity? Do you do this? And so I hope that acute care therapists are pushing themselves to learn about different medications and different technology, and that with that, we grow. That's what my hope is.
No, I think that's I think that's a great point. I mean, we always want to keep up with the evidence as much as we can. And there's always so much evidence coming out. And I think also it pushes us to like continue to put out more evidence.
Right.
I think we're always amazing things that we don't always put out there. So if you could, like, if you look at the current system, right, of acute care, if you could change one thing now, what do you think is like a good low-hanging fruit that we could like implement right away?
Well, I think, well, I don't know if this is a low-hanging fruit, or I think this is more of a challenge and a barrier, is the idea of what does early mobilization mean? And is it, I think of, like, our students think, oh, wow, you're walking a patient on ECMO. It's like, well, you need to step back and realize that there had to be stuff done before that. Like they're looking at the, a Formula One racer going down the hall that, and you're like, well, it took this much to get them there. So I think the low-hanging fruit is maybe that our students all hear that you have to do something before you get to, that golden mile, and understanding that it goes back to basics of range of motion, strength, core, transfers. And those are fundamentals to get someone out of bed in the ICU. I know we have these wonderful beds now, like Craig bed, where you can stand up and walk off.
Yep.
You know what's going to happen when they go home? So it doesn't take away from the fact, yes, we're getting them up, we're doing co-contraction, weight bearing, but the basic things of what physical therapy is around really goes back to that. Or if you have someone who, they've had some type of a spinal cord injury and you don't keep range of motion, that's going to impact them being able to sit, long sit, short sit, transfer. I mean, to me, I want that message to stay there, that the foundation of what we're all about really starts with our core. And, our students just started learning what we call fundamentals, and that range of motion, goniometry, manual muscle tests. And I'm like going, do you understand why you're doing it? It's almost like when I say to someone in cardiac rehab, you understand why we measure a blood pressure, right? That if we don't do a measurement, we have no objective finding of where you're going to progress, or if you have high blood pressure, coming down from it. So I really want to emphasize it's not all about moving that far forward with staying on that technical, development. It's also having our students appreciate why we teach them those things. And
Well,
I don't know if I answered your question, Ashley, but that's just it's in my.
no, you did. I mean, it's like, don't forget the small things that really matter, right? I think we hear so much about like what we can call it sexy in acute care, right? Like we're walking this person on ECMO, or they've got a femoral line and we're getting them up, or they're on like 20 lines and leads and here's we're down the hallway, right? And I think that's what we tend to hear about the most. But I think we sometimes forget to talk about all the things that happened before that, right? Because it's not sexy. It's not as like people, I don't know. Do you know what I mean? I say sexy, but I think that's it. Like people are excited to talk about those big things, but we don't always, I think, put out there all the other things that went before that. I think you're so right.
And I go along with that is you think about the medical and surgical team, they're at the nursing station, and when you get their patient to go by, right? Oh my God, this is wonderful. PT is amazing. And it's like, but they don't appreciate how many weeks or hours or, moments of emotional time that first time that patient's sat up in bed after maybe being, fine, and they have an emotional breakdown. And the medical surgical team didn't see any of that, but you saw it because you lived it with the patient. And I think we can't forget that part. We can't forget that it starts with one step. It's kind of like our first step on the moon,
It reminds me of a story of a patient I was seeing in the cardiothoracic ICU, and the surgeon comes in and he's like, I want him walking. Like, I want him up and walking. And I'm like, he first needs to be able to stand up. Like, I was like, he doesn't even have like 3 out of 5 straight. Like, he can't even stand up right now. We will get there. Not walking today. But that is what they, that's what they hope to see. You're right. But I think they don't always appreciate all the things that need to happen before that can happen.
Well, I think it's interesting that a lot of the floor I was just on this morning with the resident, it had a bell. And so if the person did the lap, they rung the bell. And I'm thinking, that's great because it's right at the nurse's station, right at the front of the entrance to the ward, and everyone sees that. But they don't see everything that the physical therapist, the occupational therapist, the speech and language therapist did to get that person there. And so they could even phone it, that it takes a team. And I'm just happy to be part of that team.
Oh my gosh, I just had an idea. You're talking about the bell, and you know how like when you go to like a bar or a restaurant and somebody gets a really great tip, they'll like ring the bell.
Right.
Everybody knows. I'm thinking like, why don't we put a bell in the rooms, right? So like when a patient does something amazing, like sits up for the first time, like where's that for the, we ring the bell from the room too, and they can hear it everywhere.
Right. It's a goal. It's a functional goal. We have to go to that marker over there and you can ring the bell.
We got to start celebrating the small things. So then they think those are valuable too, right?
Absolutely. So, but yeah.
I have a clinical education question for you, and I feel that we might be biased because we're all in from the acute care. Do you believe that it is important for all students going through a PT education to have some acute care exposure, whether it's a short clinical, long-term, a full clinical? Do you feel that is something that is necessary for entry-level DPT education?
So I'm going to answer it in twofold. So yes and yes.
Okay.
I strongly feel that you are seeing, if you're in home health, you're in rehab, you're an outpatient, you are seeing sicker patients that used to be staying in the hospital. They're not there anymore. Now they're being discharged sooner, quicker, and sicker. And so that's the first thing I say. The second thing, advice I try and give to my soon-to-be graduates is, what if you did a year of acute care? I said, don't think of it as a setback. Think of it as a step forward so that you have more clinical, critical thinking skills that if a person changes in front of you, you have a better understanding why and what's happening. And, why did they go pale? Why are they all of a sudden diaphoretic? Because you spent time on acute care, you were with the sicker of sicker patients, but in a safer environment.
Right.
And, I'm going to do home care. I'm like, okay, you do know it's just you, as opposed to in the intensive care unit where you have a whole team around you, you have monitors and everything helping you make decisions. So I say yes and yes. Leo, I really feel strongly that a student should have some experience because, you just don't know what's going to happen. You don't know. And, I work down here and Ashley works down in the South also, and heart disease and a stroke, obesity, diabetes, hypertension. It's like this big red thing, the part of the U.S. down here. And so how does a student or how does a new graduate recognize when someone maybe through a PE after having orthopedic surgery? How does someone recognize if someone all of a sudden they call it be fast, there's a change in balance, a change in eyesight, the face, the arm, the speech, and, how does someone recognize that unless they've had someone push up, like a ClinEd person, a clinical instructor, or someone who's got such passion that this is going to take with you for the rest of your career as a PT, that you would know this?
Well, I'm going to take a play out of your playbook, Leo, with this transition. Speaking of clinical experience, Kathy.
Yep.
Tell us what happened on your first clinical experience.
So I learned my lesson that day. So when I was in PT school, every Thursday we had to go on into a clinical setting, and I got linked to a nursing home. Well, I grew up in Vermont. I went to school in Vermont. And so I had wide whale corduroys on, a cowl neck sweater, and a lab coat. And I walked into this individual room with my clinical instructor. And I don't know if you've ever been in a nursing home, they keep them very warm. There's unique odors that I wasn't quite ready for. And I had a lot of insulation on, and I went down like a rock. And so I woke up in the hall because my CI had dragged me by my collar, and she went back into the patient's room to work with them. And I was kind of like this, and this lady was wheeling by me in a wheelchair, and she goes, "Are you okay?" And I'm down there on the floor going, "Where am I running?" And so I go in, I find my CI, I apologize, and I said, "Please let me apologize to the patient." And she goes, "But she won't remember you." And I thought, really? I would have thought I would have been memorable that I dropped like a sack of potatoes down on the floor. And she goes, "No, she won't remember, but go ahead." And so then I went in, and with my CI, I did the evaluation, and the woman had no recollection, but I will always remember waking up to having someone wheel by in a wheelchair asking me, "Are you okay, honey?" And me going, "Fine."
Were you on the floor? I'm just imagining this. Like,
Oh, no, I was on the floor, and with my thick cowl neck sweater, my CI dragged me out in the hall to get fresh air, and she had to do productivity, so she left me there and went back to work.
Oh my gosh.
I gotta be productivity. We don't have time for this. We're just gonna drag you out. I'm gonna go back to patient care.
I'm here, I got a lot of focus. She'll wake up at some point, and she was right.
I think for all the students and CIs listening, like, if you as a student pass out, or if your student pass out, it does not mean they're not going to go into acute care one day, right?
Absolutely not. It became an absolute love. I will say one of the things that doesn't bother me anymore are odors, and you become a little bit immune to it. But I would have to say fainting humbled me and made me realize that, wow, okay, it's not just walking in thinking you can do everything. It's like, just realize you've got a body too. And if you don't have breakfast, if you don't hydrate and make sure you have water, and you wear a cowl neck sweater under a polyester jacket, there's no breathability, So I learned a lot that day.
It reminds me of a story when I was working in the cardiac ICU, and they used to keep the oxygen underneath like this kind of shelf area. There was a patient, he was, really not completely with it, like partly sedated. And I was trying to get the oxygen off, like to move it over to like an oxygen tank. And I was yanking and I was yanking. And finally I was like, I'm just going to have to give this all the force I have. And I don't know what get. And when I do, my head flies up.
Oh, no.
They shelf. Like, I'm surprised I didn't have a concussion. I fall over into the guy's recliner chair. And I literally had to sit there for about 5 or 7 minutes to be like, oh my gosh, I'm like seeing the room spinning, birds around my head. And in the meantime, I was like, did I remember to put his oxygen back on? Like, it was horrible. And I remember thinking, oh my gosh, he's going to think I'm an idiot. He's not going to want me to treat him. And of course, I look over and he's not even seen or noticed any of this. And these people are like, are you okay? I'm like, I'm fine. I'm fine.
Go over like, yeah.
Oh my God.
I remember the first time I cried I was being trained on, and I was going at that time, the cardiothoracic unit, there wasn't a pediatric cardiothoracic. So they brought the pediatric surgeries to the adult unit. And it was my first time ambuing someone who had just had open heart surgery. The mentor across from me was like very strict and was like keeping the pressure between a certain mark. And I've got the face shield on, I've got the gown on, and the tears are just flowing. And then the surgeon came and stood behind me to make sure the pressure stayed perfect for that little guy. And I was just like, let him cry. And I was like, oh my God, he sees me cry. I don't care. I still remember that day, how scared I was, but I was like, you know what? I can get little puffs on a teeny little manual ventilator to a baby. Just give me that baby again. But that day,
wow.
I've had happy cries. I've had sad cries. I've literally gone into the bathroom, locked the door, and cried at times. Like, if certain patients like gone to me in certain ways, like, yeah, we all have our moments, I think.
I've got a long list of them. And I think it's important for my students to know I'm human too.
Yeah.
And I didn't have, there are moments when I don't have confidence and I don't know an answer. And I'll make sure that it's okay to say that. I said, that's how you're self-aware. If you go in and think you're going to do something and you're like not confident, then you're going to hurt somebody or you're going to get hurt yourself. And so I don't know if they appreciate my fainting story or they appreciate my crying story, because I think they feel I put them that way sometimes. So,
I definitely tell some of my horror stories and hope they learn from it and don't make the same mistake, right?
Well, and sometimes they have to do their own mistakes.
Yeah.
You just don't want them to get hurt or a patient to get hurt.
Yeah, absolutely.
But those are great teaching moments. They're fantastic teaching moments. Absolutely.
Leo,
Yep.
I think it's time.
Oh no! Oh no! What does that mean?
It is time for rapid responses.
Oh, no. Okay. All right. Okay, I'm ready.
Remember, they're rapid responses, so don't overthink it. Just we're going rapid response. We gotta react. So whatever pops into your mind, I'm gonna hit that answer.
Okay, I'll do my best.
All right, I've got 60 seconds on the clock.
You want me to start off?
And go.
Kathy Lee, what's your most favorite dessert?
Ooh. Oh no. Ooh, chocolate chip cookie dough ice cream.
What's your favorite outcome measure to use in acute care?
5 times sit to stand.
If you were not a physical therapist, what profession do you think you'd be in?
I'd be flying an airplane.
Oh, hey.
Remember, military.
Right. Are you a morning person or a night owl?
Oh my God, such a morning person. 5 a.m. comes and I am ready to vacuum. I'm ready to get everything. The dogs and the cats are like, is it time? Do we need to get up? And I'm going.
Favorite scrub color?
Well, I wear black, 3 days a week with scrub colors, but I really kind of like the seal blue.
Ooh, steel blue. Awesome.
What book would you recommend?
Oh, that's tough. I'm about ready to read a book by Dave Grohl. I just love that he's more than someone from a musician, that he's got some wonderful stories with Paul McCartney teaching his daughter about piano. So I'm kind of excited about reading that. I'm going on vacation next week. It's coming with me.
Favorite way to exercise?
Oh, tennis.
Tennis.
And it's our timer. Last question. Great. You know you work in acute care when
smells, blood, they don't get you upset. They excite you. Or my other one is when I see an MRI where the lung is completely destroyed, but yet I can get that patient up and go, how the heck are they breathing? That kind of excites me.
That's a good one.
Kathy, I noticed you mentioned tennis. I'm also looking at some of this information. You had to actually use your CPR on the tennis court, huh?
Yes. A week ago, we saved a gentleman, and I don't even know how long he was down on the court. Someone came running around and said, we need help over here. And my boyfriend yelled, toe. And I went, okay. And so I ran over and I just started bossing people around and saying, okay, get his shirt off. Let's get the pads on, start CPR. And it just was a blur. I have no idea how many minutes the whole thing was. I know how many cycles of CPR we did before it shocked him. And the good news, he just got discharged from the hospital yesterday.
Wow.
Wow.
What a story.
That's pretty. And you know you work in acute care when you run to the emergency rather than away from them.
Yeah.
Absolutely. And it's the second time I've done CPR on a tennis court.
Oh my gosh.
So
I hope it was you there.
Yeah, I mean, or I'm just like bossy and happen to be in the right place to say, let's do it. Come on. No pulse. We all know what to do.
Right. And
if we're going to go down on a tennis court, I'd want you there.
Right. Well, Kathy Lee, congratulations again on the Catherine Harris Teaching Excellence Award. It was a pleasure working with you on Bridge the Gap, and it was a pleasure having you on the show today.
Well, thank you. I had a lot of fun. So I hope someone enjoys this and they find that acute care may be something they're interested in, and would love people to think about an acute care residency because it's a year of mentoring. There are 16 programs in the U.S. now for acute care residencies, and that in itself shows us where the acute care is going, and that the other places all around the country feel that there is a benefit to having this, and I'm very proud of those other 15 organizations that develop their residencies also.
That was a great plug in the podcast.
Did you like that?
Thank you, Kathy.
All right, take care.
We would like to thank Kathy Lee for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. It is hosted by Leo Arguelles and Ashley Poole. Executive produced by Katie Brito and Edward Mathis. Music by Alexi Action from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for another conversation with an engaging acute care guest. Thank you for listening, and may your shoes and scrubs stay clean today.